one thing that we are very keen of, making sure that everyone from the ground, from the national level, regional level, district level, to community level is involved. Because as we all know, messages are very sensitive. So you cannot just take a message which has not been validated at all these stages. So that also we make sure that is considered in this program. Thank you so much.
Thank you very much. Thank you, panelists. Let us put our hands together for them. Yeah, perhaps because of time, we may not get adequate time to conclude, but I'm going to give a favor for 1 minute to one of the panelists. That's no other than Fatuma to conclude. Fatuma, una ushauri gani kuhusu wasichana kuhusu swala la kwenda kupata chanjo HPV? Una ushauri gani?
Asante. Unajua katika familia zetu kuna matabaka mawili. Kuna watu walioelimika na wasioelimika. Kwa hiyo kama binti mwenyewe umeelimika na mzazi wako unajua kabisa hajaelimika, lazima umelimishe kuhusu hili. Na tujibebe jinsi wanavyozidi kutupa elimu, wanavyotufikia vile tulipo huko Uswahilini, unaweza kusema hivyo kwa sababu wote tuko mbali. Wanavyotufikia kule mitaani, wanapokuja kutupa elimu kuhusu chanjo kule nini, inakuwa ni vizuri. Basi wasiishie tu kwa mabinti wao, wanakuja hata majumbani vile, wanawapa elimu na wazazi, kwa sababu tuna matabaka mawili, walioelimika na wasioelimika. Wazazi wasioelimika ni wazazi ambao ni wagumu sana. Wanaweza kukwambia hivi, sisi tumeishi bila hiyo chanjo na tulikuwa tunaishi bila saratani. Msije mkachanja tu mtakuwa mpati watoto. Hiyo ndo wamekaa sana katika hizo imani. Kwa hiyo nashauri tujibebe, waendelee na hizi nani zao kuelimisha hivi katika maredio, katika social media, kila sehemu, ili waweze kuwafanya wale wasioelimika tuelimika, ili wazazi wawe miongoni mwa kuwashawishi watoto wao kwenda kuchanja. Kwa sababu mimi siwezi kuchanja bila kuwa na ushawishi wa mzazi wangu, ili nijione na mimi nipo na mzazi wangu, ninachofanya hiki kitu ni sahihi.
Thank you very much, Fatuma. This marks the end of our panel discussion. However, for the coming few minutes, we have a special activity that the lead person is going to tell us. Karibu, Rita. Thank you, the panelists.
Nashukuru sana. Asante moderator. Tumpigie moderator makofi. Professor Kakoko. Thank you so much. Yeah, very quickly, we are very thankful for everyone who joined our session. And it seemed it's a very active topic, HPV, because we had a lot of questions. And if we left more time, I know we had more than that. So we today also, we are glad that our EPI, Dr. Tinuga, is officially going to launch our program, our immunization program in the 4 regions. And this program is, the name of the program is called Mwanzo Mwema. So before I welcome Dr. Tinuga, I'm just going to explain why we call this program Mwanzo Mwema. So that's the beautiful beginning. It's a beautiful beginning for the young children because this program we are covering routine immunization but also HPV for the 14 years old. For we know that if these young children who are under 3 years old get all the required vaccinations, they have a beautiful beginning of their future. And the young girl who's a 14 years old girl, we expect that because she'll be having this vaccine, it will be protecting her from cervical cancer, and she'll have a brighter future. So we expect that this young girl will have a beautiful beginning of her adolescent years. So that's why we call this program Mwanzo Mwema. And I would like to welcome Dr. Tinuga to come and say a few words. Thank you so much, Dr. Tinuga and Dr. Chaote, for your support. And also Dr. Ntuli has been very, very supportive to this program. We appreciate all the other Minister of Education for their effort in making sure that this vaccination program is a success to our country, Tanzania. So thank you so much, Dr. Kinuga. Karibu sana.
Thank you so much, Rita Mbeba, for inviting me to say some special words in this particular session. I'll be speaking on behalf of Dr. Halid Massa, who is the Director for Department of Preventive Health. He has been not able to attend this session due to unavoidable circumstances. So on behalf of him, and based on the time we have few times, I had to read all the speech, but due to limited time, I'm not going to read the oral speech, but I will see some few words to emphasize on what is being presented. So, ladies and gentlemen, the Mwanzo Mema project basically is going to address what has been discussed during the panelist discussion. It is going to create the demand for girls at 14 years of age to increase the uptake of HPV. That's the thing. And Mwanzo Mema, it has already started, so this is the official launching of it, but field visit has been, activities have been started. This is why we have some RHMTs from Shinyanga, led by the RMOs. And Mwanzo Mema, as the government, we expect a lot from them. You have heard the questions directed to girls' effect on how are they going to engage with the government in both the MOH and the Pure Large in addressing all the challenges we have discussed. So one of their strategy is through Mwanzo Mema. And Mwanzo Mema is going to be implemented in 4 regions, and these 4 regions, indeed, when you look at them in terms of uptake of HPVs, not only HPV, but also the immunization antigens, as I mentioned them, for the under 5s, including also the COVID-19. So they are going to focus in Katavi, Shinyanga, Rindi, and Mtwara. Good thing of Mwanzo Mema project, it will go hand in hand with the government's vision we have just described of making transitions from 2 doses of HPV to single dose, but also increasing the scope of the age category from 9 to 14. So we expect a lot with Mwanzo Mema project during the scaling up of those. So with those few words, and on behalf of the Ministry of Health, on behalf of Department of Preventive, I would like to declare that the Mwanzo Mema project is officially launched. Thank you very much.
The session is not over. Please, we are not yet done. We have a couple more minutes. Moderator, I know we have a couple more minutes. The next session, the next activity is what? Okay. Yes. There's a short video, and before the video, there's going to be a short story from one of the organizers. Please tell us about the story.
Okay, thank you. So if you look to your left, you'll see we're about to play one video about one of our videos for HPV. One thing that Girl Effect is very good at is we know when you talk to young people about vaccination, you need to speak in their language.
Please, we're still in session. Thank you.
You need to speak to young people in their language. So we try to create innovative and entertaining spots to talk about health issues. So please, let's maintain silence as we listen to the video on your left.
Don't play it, but... Okay. Here's the video. Round of applause to Girl Effect and to Jibebe and for the launch and for the beautiful session. Kama sisi tunaweza, kama wao unaweza na sisi tuna. Asanteni sana Girl Effect that bring the session to a close, and we can't thank you enough. Stay with us in Mikumi Hall as we transition to the last event of the day, of which my colleagues at the back are going to display. And the last event of the day will start in the next few minutes, and that will be the DATA.FI forum from 4:30 to 6 p.m. The speakers for that session should get ready. We expect, and we are going to start on time, like we have always been in this room. So I would like for us to buy a couple more minutes as the moderator and the panel and ourselves are going to get ready for the next event. Karibuni sana. Mabibi na mabwana, ladies and gentlemen, welcome to the next session. By show of hands, who else knows how to mention the name in red and black? Who else knows how to, not the people from that name, who else knows how to mention well the name in red and black? Who else wants to join me? What is it called? I am the only one in the room who said DATA.FI. That's a beautiful way to make sure that I don't get it wrong the next time. So DATA.FI. And I had a very beautiful explanation at the back that as long as there is a dot, the next letters you have to call them out, right? Yes, that's I'll never forget that. So with that, we would like to welcome you all to this hall. And we are really happy that you are the first. If you flip the page, you become the first session, right? At the end of the day, I would like to call upon the moderator for the session, who is then going to bring the panel, and we'll get started. Everything that you're planning, all to you.
Good evening, everyone. My name is Dr. Irene Haule. I'm a doctor at PURAJ. Today I'm going to be the moderator of this session. I can assure you you have made a right choice to be in this forum today, because it's going to be a very exciting forum, and we are going to learn a lot from the experience which we are going to gain from different CHMTs. So, for the sake of the time, I would like to call the presenters who are going to present today. And actually, we are going to have a presentation from 4 CHMTs who are going to present on the experience of data use and showing how data has helped them in making some good decisions and improving health services. So I would like to call upon Stella Nyamtondo Mujaya. Stella is a dedicated and committed public health specialist with 20 years experience of leading and managing high impact programs, research and evaluation activity. She has a unique mix of skills in nutrition, family planning and reproductive health, and data analysis and data utilization expert. Currently, Stella is playing 2 roles at Palladium. She's leading a DATA.FI portfolio in Tanzania, serving as a country director for the project and country representative for Palladium International in Tanzania. Please, a round of applause for Stella Nyamtondo. Karibu sana. So another presenter, is Selina Ivanja Majele. Selina Ivanda Majele is an assistant nurse officer from Mpwapwa, DC. She has 27 years experience in working with primary health facilities, and currently she's a family planning focal person at Mpwapwa, DC. Please, tupige makofi kwa Selina. Our next presenter is Masanja Lumejega. Masanja is a doctor with 7 years experience of clinical experience and a proven track records in healthcare quality improvement, dedicated to enhance patient care, optimizing process, and ensuring compliance with healthcare standards. Please, Masanja, karibu sana. So we also have another doctor, a presenter from Temeke Municipal, Dr. Timothy Bende. Dr. Timothy Bende is a medical doctor with 8 years experience in working with health facility in municipal level. Currently, he is serving as a project coordinator of health at Temeke Municipal Council, and he is a member of Council Health Management Team for over 3 years, experienced in provision of support on project planning, monitoring, and evaluation for municipal level through CHMT. Please, a round of applause for Timothy Bende. So we also have another presenter, a lady from Ilala Municipal, Aisha Zuberi Ali. Aisha, she is a Senior Assistant Medical Officer with 17 years experience in working with health facilities at district level. Currently, she's serving as a City Council HIV/AIDS Coordinator in Dar es Salaam. Tafadhali makofi makubwa sana kwa Aisha. And lastly, we still have two more. We have a medical doctor working as District AIDS Control Coordinator with 3 years experience in multiple monitoring and evaluation systems such as DHIS2, CQI, and other systems. Please, a round of applause for Dr. Emmanuel Bia. And lastly, we have Flora Ignas. Flora Ignas is an assistant nurse officer with 13 years experience working in health facility and district hospital. Currently, she's serving as a quality improvement and infection prevention and control focal person at Kondoa Town Council. She has Dada Stella to start with the presentation. Karibuni sana.
Thank you so much, Madam Haule, for the glorifying introduction. Habari ya jioni, habari ni jioni. A good one to every one of you. Welcome to the session. Before I take us through the session, I would like to acknowledge the presence of the DATA.FI Tanzania team who are sitting, in the chairs. If you can stand and wave for everyone to see you, please. Thank you so much. So my role today is really to steal a few minutes of your time. Kiini cha presentation really is the experience from CHMTs, but my role is to take a few minutes of your time to talk a little bit about Palladium, the company, but also today we're featuring DATA.FI project, so I'll talk a little bit about what we're doing globally because it's a global project, and my colleague will take us through what we're doing in Tanzania, our scope in Tanzania, and then we can hear from the CHMTs the experiences that they have gained from the initiative that we've implemented in collaboration with PO Large. Yeah, if you can skip that slide, please. Again. Yeah, next one. So for those who have not heard of Palladium, Palladium is a for-profit company. We have been around for over 50 years, and we are present in over 90 countries, Tanzania being one of them. And as you can see, and so we've been creating positive impact in those 90 countries. And as you can see, I've tried to show the projects that we've been implementing in Tanzania. We've been around from 1971 in Tanzania, implementing projects around the area of health, WASH, education, innovation ecosystem, private sector, as well as governance. Right now, our portfolio is, we're focusing on those 4 projects. The other ones have already closed. We have NPI Expand, if you've heard of it. We have Achieve, which we are subbing with PACT. We have Data for Impact. We have GGF and Government Innovation Fund. So today we will feature Data for Implementation, a long form for Data.FI. Next. Next slide. Yeah, so as I mentioned, DATA.FI is a global project. We bring together leaders across the digital health and analytic landscapes to harness the power of data to save lives. It's a 5-year program which is ending in December 2025. We are implementing with a consortium of partners. You can see those are the list of partners that we implement with, but Palladium is a prime. And we can say our expertise lies in those four main areas. Across the different countries that we work with, we provide support in the area of digital health systems. So we build systems, we enhance, we integrate systems, but also we do data analytics and application of artificial intelligence, predictive analysis. We also do decision support interventions, and this is what we're going to hear today. We implement that through situation room approach. We're going to hear more about that. We also do data standards and governance. So we work together with partnership with local stakeholders to drive sustainable country-led solutions, strengthening local data systems. So if you want to know more about DATA.FI, we have a web there that you can feel free to dive in. And then also I'll be also sitting at the back so you can ask more questions about DATA.FI. We are happy to partner with you in any of those areas that we are experts from. Next. Yeah, so we are, I would like to say I'm very proud of the approach that DATA.FI is going with. We prioritize local partners. We work together with the Ministry of Health. These are the 4 buckets that we ensure that we have as far as implementation of the approach is concerned. We facilitate country leadership, and you can see from the project that we are going to present how we have worked with PO Large, them being the driver's seat in implementing this initiative. We also empower local partners, and in this case, we're talking about cancer health management teams, and so we can share, they can share the experiences that we've had together. We learn together, but also we prioritize, global goods. And in this case, as you can see from the expertise that we've had, we are very good in, developing systems, analytic platform, but in this case, following the principles of digital health solutions in Tanzania, we are implementing, we are supporting the government-owned system, PO Large-owned system, IMES, to be used as a data visualization analytic platform at the situation rooms that we have operationalized. Yeah, and those are the countries that we are currently working in. We have over 20 countries that we work with, including Tanzania. And with that, I wish to welcome my colleague to dive into the Tanzania DATA.FI scope of work. Karibu, Dr. Masanja.
Thank you, Stella. Good evening, ladies and gentlemen. Over the next few slides, I would like to just take up a link from what Stella was speaking about DATA.FI as a global project to share with you about DATA.FI in Tanzania. And then after that, we'll have our colleagues from the councils who will share the practical things and the work that they have been doing through the project. Yeah, so in Tanzania, the DATA.FI project came into question following the request by the President Office, Regional Administration and Local Government Authority, TAMISEMI, who actually found that there some improvement initiative that was done at Makole Health Center seemed to have produced some notable results, in particular in areas of revenue collection, the quality of care that was provided to patients, but also client satisfaction. And so TAMISEMI saw that an opportunity and actually wanted to scale up the enhanced management approach that they had implemented at Makole so that it goes throughout the country. And to do that, they requested USAID to provide support in scaling up that initiative. And then USAID contracted Palladium through its expertise in implementing data use and quality improvement initiative in order to work then with TAMISEMI to see that that initiative is being scaled up. And so that was the reason around which DATA.FI was called into, and we have the project of DATA.FI in Tanzania. And again, I think you saw this slide from Stella's presentation. It's like the fundamental approach of DATA.FI, in which it prioritizes country leadership, but also empowering local government, for example, the CHNT and RHMT, who actually formed the core part of the project implementation. And the reason here being that DATA.FI believes in also building sustainability of its projects from the start. And so involving and giving authority to the government teams and departments to be at the center of implementation of the project actually allowed them and would build that capacity for the teams to ensure that even after project exit, still the government teams that were involved could take on the good work that has been done. And also on the side of prioritizing the global goods, there was an assessment of the HIS ecosystem. And when DATA.FI found that Pure Large had already a data system that they were implementing, the Integrated Monitoring and Evaluation System, IMES, DATA.FI thought that actually to use and utilize the same system as the data visualization platform in the implementation of the project instead of creating a new one. Again, building on the same thing, that utilizing what is existence and sharing the global goods is most likely to ensure that there will be sustainability even after the project leaves. And so the gains that have been gained during the project will actually be sustained. And this is the theory of change around the whole design of the DATA.FI project, where actually you see on the far side, on the impact, the expectation is twofold. One is to improve the health outcome, meaning the indicators, the specific health indicators that are being tracked in the project. But second is to build a culture of inquiry where teams are encouraged actually to query the data that we collected through routine health activities and make use of those to improve the health outcome. And so the belief was that investing in space and technology, providing technical assistance and stakeholders engagement as inputs would provide those user-friendly environment to stimulate data use. And in particular, the first point about space and technology is that the DATA.FI project built or refurbished a situation room, so-called situation room, which are actually rooms that were existing in councils, but then we were furnished with furniture and created a system where the CHMTs could sit together and then review data from their data system using screens. So that way, you could enable a collaborative and teamwork review, a critical review of data that they have from which they create solutions. And then with those inputs, some of the activities that were undertaken included actually the design workshop, which was more of teams coming together, analyzing data critically, and then proposing solutions as to how can they improve what they have seen from the data. So that's the council design workshop. And then whatever plan they create in the workshop, they go on to implement them during routine situation room meetings. And again, the word regular situation room meetings there is key because the belief is that frequent and repeated review of data will not only improve its quality because you are inquiring and looking at it repetitively, but will give you that opportunity to continually reflect on what to do and adjust so that you get the improvement. And then with the hope is that if you do that, then we would end up on the outcome side of having improved the council performance because we'll be looking at data around health indicators. You'll be documenting what you're doing. And so actually you even have a chance of cross-learning where one council can share with the other about what are the best practices they're implementing on an intervention and actually scale up whatever good thing that you're getting from one project to the other. So in a nutshell, again, this is just the same thing. At the center of it, you see there's the PDSA cycle, the famous PDSA cycle from quality improvement, where the teams sit down, plan, implement their plan, do some studies around how is the plan actually coming along in terms of improving whatever they wanted to improve, and then act, meaning having the feedback from whatever the studies that you have made about what are the interventions you're implementing, are they working, and then what should you do moving forward. Next slide. Yeah, and so again, this is another recap of how that process ran. On the upper left corner, you can see there's a graph there. It's the starting point of the process where teams sit down and review data. And then you'll see on the upper right, a team of people deliberating on what could be the potential root causes around whatever performance they have seen in data. And down here, you see a mechanism of documenting their theory of change. It's a driver diagram, a famous QI tool, and to how then can they drive improvement towards the goal that they have set after reviewing data. And on the lower right corner, they can see an action plan template where they document what exact steps they are going to take in order to achieve the improvement or the targets that they have set after data review. Yeah, and so having said that now, can I please I'll be welcoming our colleagues from the councils to then share actually how did they do that data review and how did they carry out the process of improvement all the way to seeing the outcome. And to start, I'd welcome Mama Selina from Mpwapwa.
Habarini ya jioni. Niko hapa kwa ajili ya kushare experience kutoka Mpwapwa DC kama member wa CHMT. Sisi Mpwapwa DC tulikuwa na indicator ya kuimprove HIV viral load suppression kwa kina mama wajawazito na wanaonyonyesha below 50 copies. Kwamba kwa wale kina mama ambao wamepimwa na kuonekana HIV positive, tunaita PMTCT1, basi tuweze kusuppress viral kwa kiwango cha 50 copies. Tunaamini kwamba mama yeyote akisuppress viral load kufikia 50 copies hawezi kumwambukiza mtoto wake. Na kwa kuanza tulianza na data ambazo tulifanya data review ya Juni 2021 mpaka Mei 2022. Na data hizi tulizitoa kwenye DHIS2 report. Kwa kupitia hizi data tuliona kwamba kulikuwa na changamoto ya report kutoka vituoni, lakini pia kulikuwa na changamoto ya viral load suppression kwa kina mama ambao walikuwa HIV positive. Lakini pia tuliona kwamba wale kina mama ambao walikuwa matured kwenye cohort ya miezi 12 pamoja na kupimwa hawakuwa wameweza kusuppress ile viral load kama inavyoonyesha pale. Sasa baada ya kuziona hizo changamoto tulikuja na root cause ambazo tuliona kwamba kitu gani kimetusababisha sisi tushindwe kuperform viral load suppression. Tukaona kwamba kuna knowledge gap kwenye MC cohort. Tunaposema MC cohort ni ile register ambayo inatumika kuwaandikisha akina mama wote ambao wananyonyesha na wajawazito waliogundulika kwamba ni HIV positive. Kwa hiyo tuliona kwamba hatuna gap katika MC cohort, lakini pia tuliona kwamba kuna delay availability ya hizi MC cohort tools. Na tuliona kwamba kuna inadequate supportive supervision kwa CHMT kwa sababu ya knowledge gap. Kwa hiyo wao kama CHMT hawawezi kwenda kufanya coaching chini kule kwenye facility kwa sababu walikuwa tayari wana gap ya knowledge. Na tukaona kwamba kulikuwa na low data quality kwenye MC cohort kulingana kwamba zile tools hazikuwa aware kwa wale provider wanaozitumia. Na pia tuliona kuna inadequate data review kwa upande wa CHMT on MC cohort ambacho ndicho chanzo cha ile report tunayoifanyia kazi. Na mwisho tuliona kwamba kuna baadhi ya kina mama walikuwa wana miss opportunity ya viral load testing ambao ni HIV positive, wale wajawazito na wanaonyonyesha. Ndio ilitupelekea kuona kwamba tunafikia hatuperform kwenye ile 95% ya viral load suppression. Kwa hiyo hizi ndizo zilikuwa root cause. Baada ya kuona hapo sasa tulikuja na change ideas. Kwamba tufanye nini baada ya kugundua zile root cause. Kwamba kwa sababu kuna gaps kwa CHMT, basi tufanye CHMT coaching kwenye MC cohort register. Kwa hiyo CHMT wote walikuwa coached kuhusiana na MC cohort register ili wao wawe aware. Na baada ya kuwa aware sasa tulishuka kwa hawa healthcare workers tukawaorient na wao kwamba wawe aware katika zile tools wanazozitumia na kuwagawia sasa zile tools. Kwa hiyo tulikwenda tukawagawia tools na tukawaorient wale healthcare workers ili wawe aware. Na pia change idea nyingine tulioitumia ni kuconduct monthly data review. Kwa hiyo baada ya kusurprise zile tools tukaanza kufuatia na tumeshawa orient. Sasa tuanze conduct supportive supervision kwa kupitia zile data ambazo tulikuwa tuna identify. Kwa hiyo kupitia situation room tuliweza kuchakata data, tukagundua zile gaps ambazo zilikuwa kule vituoni kwenye health facility na tuliandaa checklist ya supportive supervision. Tulikwenda direct kwenye kile kituo ambacho kina shida, ambao tayari tulikuwa na zile gaps. Kwa hiyo tulikwenda kuwajengea uwezo kupitia zile gaps walizokuwa nazo. Lakini kitu kingine ambacho tumefanya kama CHMT na tunaendelea kukifanya, tulijiengage kwenye community healthcare workers kwamba wao sasa watoe health education kwa wale akina mama wajawazito na wanaonyonyesha umuhimu wa viral load testing. Kwa sababu bila kutesti hauwezi ukajua mama amesuppress au hajasuppress. Kwa hiyo tulikwenda kuwa equip wale healthcare workers kuhusu kuwaelimisha wale akina mama umuhimu wa viral load testing. Na baada ya hapo sasa tuliendelea kuintroduce 3 boxes ambazo zilitusaidia kufanya follow up kwa wale akina mama ambao walikuwa ni missed appointment. Kwenye 3 boxes zimetusaidia sana. Wakati wa ile siku ya huduma tulikuwa tunakusanya zile faili zote zinazotakiwa kufanywa kazi, tunaweka kwenye box ya kwanza. Kwa hiyo ile siku ya kazi tunatoa huduma, na baada ya hapo mwisho wa session ya ile siku zile faili ambazo client hawajaja tunahamishia kwenye box ya pili tayari kwa tracking kupitia hawa CH. Na kwa kufanya hivyo tumeweza kuwafikia wale wamama kwa sababu tulikuwa tuna take action mapema kupitia zile 3 boxes. Kwa hiyo kupitia kuwapata wale kina mama mapema kutesti tulikwenda na wakati, na ndio maana huko mbele tutaona kuna percentage ambazo tumefikia baada ya kuzichakata hizo data. Kama tunavyoona hapo ni improvement outcome baada sasa ya kutumia ile situation room. Tukiangalia hapa ni before SCR initiative. Tunaona kabisa, kwa mfano tukianza na kutafsiri hizo rangi, hiyo namba 1 inaonyesha idadi ya kina mama ambao walikuwa tested kwa ajili ya HVL. Blue, njano inaonyesha akina mama ambao wamesuppress viral load ambayo ni 50 copies, na black inaonyesha kwamba vituo ambavyo vimecontribute kufanya hii HVL testing, na kijani inaonyesha kwamba ni percentage ambayo imefikia. Kwa hiyo tunaona before kwa mwezi Agosti tulikuwa na 100%, lakini ukiangalia vituo vilivyo contribute vilikuwa vichache. Lakini tukija Septemba hapo tuliona tulikuwa na 10%, kitu ambacho hapo katikati hapakuwa na data kabisa. Kwa hiyo ile gaps ya reporting ilionekana hapo. Lakini baada sasa ya kuanza kutumia situation room kuchakata data, kugundua vituo vyenye uhitaji wa supportive supervision, tuliona kwamba sasa baada ya pale ndo tutaona matokeo ile ya 100%. Kwa hiyo sisi kama CHMT wa Mpwapwa imetusaidia sana hii situation room kuchakata data na kwenda moja kwa moja kugundua lile tatizo na kulifanyia kazi mapema, na ndo maana tukaona yale matokeo ya 100% kwa HVL suppression kwa kina mama wajawazito na wanaonyonyesha. Changes ambazo zimetusaidia sana, priority changes zilizotusaidia sana, tumeona kwamba tumeimprove data entry, lakini pia tumeconduct PMTCT outreach kwa ajili ya kuwafuata wale akina mama ambao wamemiss zile appointment ili waje wacheki ile HVL. Lakini pia tumeprovide special PMTCT clinic kwa kina mama na watoto. Siku za nyuma mama alikuwa anakuja kliniki peke yake, lakini kupitia uchakataji wa data tuliona kwamba mama aje pea na mtoto wake wote wapate huduma siku moja. Lakini pia tuliweza kuconduct supportive supervision na coaching kama tulivyoongea hapo mwanzo. Kitu gani tumejifunza kupitia situation room? Tumeona kwamba situation room imetufanya sisi tuweze kuchakata data na kugundua gaps. Kwa hiyo kupitia hivyo tumeweza kufanya effective supportive supervision ambayo imetuletea kufanya follow up ya PMTCT na CTC services. Tumeimprove kwa kiasi kikubwa. Lakini pia kupitia hapo, kupitia zile action plan ambazo tulikuwa tunadiscuss na wale watendakazi wa vituoni, imetusaidia sisi kuweka malengo na kufikia ile target tuliyokuwa tunahitaji. Na mwisho wa siku sisi kama CHMT imetujengea teamwork, kwamba hii kazi angeweza kufanya mratibu mmoja tu anayehusiana na mambo ya PMTCT, lakini leo ukienda kwa CHMT members yeyote anaweza akaenda akafanya hii kazi. Kwa hiyo tumekuwa na teamwork katika CHMT yetu. Pia tumekuwa na imetujengea tabia ya kuendelea kuchakata data kiundani. Kwa hiyo ni kitu ambacho tunaendelea kukifanya ili kuendelea kuboresha yale mabadiliko. Asanteni kwa kunisikiliza.
Good evening, ladies and gentlemen. May I present, I'm going to share with you the experience from Temeke Municipal on the indicator of improving the proportion of pregnant women attending the first antenatal visit below 12 weeks of gestation age. We know that we have a lot of indicators which we are implementing on it, but this is the most terrible and hard indicator which was disturbing us. So we are going to present on it because there are some changes we have made, so it's better we share what we did and what we have until now. So our main context is on the importance of early booking. As you know that the mortality rate is the global public health issue, which is contributed by the late or delay of management of pregnancy complications. And this results from not less or less improvement of the antenatal care. Our moms, our sisters, they attend to the facility during labor with several complications, but this is due to late attending to the facility. You may find the mother attend to the facility with anemia, low HB. Other clients, they attend with higher blood pressure in labor. So once you delay to manage this, it results into maternal mortality rate. So our aim was to improve the antenatal care of both the sisters and the mothers who are coming to our facility. So how do we improve the antenatal care? There are several interventions which we needed to improve. Some of the improvement are site-based, and some, the most are the site-based, where on the site-based, we deal with those clients who attend to our facility, making sure that we screen them. After screening them, we link to the clinic. And other thing is all women with UPT positive, we make sure that they cannot leave the facility without being linked to the RCH clinic. And there are several interventions like outreach services where we attend to the community and screening them. But we are grateful of DATA.FI, Palladium DATA.FI. They introduced the approach of situation room approach, whereby as the member of CHMT or CHMT team, you sit and you review your data through situation room approach. So by using situation room approach, we reviewed our data and we identified there are several challenges which may hinder to attain the target. Next slide, please. So by reviewing data through situation room, we identified that we have long time without attaining the target. The national target of antenatal visit is 60%, but Temeke CHMT, we reviewed that to attain this, because of these challenges, we decided to set another target, which is 30%, which is attainable to us. But from January to September 2022, we did not attain the target of 30% due to different reasons. First one is low coverage of early booking at health facilities. We have low coverage of those mothers. Then we identified that the community, they are not aware of the importance of early booking. So that you can see our performance from January to September, they are not satisfactory. So what we did, after identifying these challenges, we went and tackled and solved the challenge so as we can help these mothers and our family so as we attain the target, municipal target and national target. Next. We reviewed what are the root causes which may hinder to attain those challenges. Baada ya kuona, tukaona ni bora tupitie hizi changamoto zinazopelekea tushindwe kuattain hizo 30%. Baadhi ya hizo changamoto ni kama hizi, ambao ni low level awareness on the importance of early booking in the community. Lakini pia nyingine ni low involvement ya CHW, community healthcare workers, on early booking message on part of CHW message into the community. Lakini nyingine tukaona ni low community healthcare workers motivation. Hawakuwa na motivation, that's why hata utendaji kazi wao haukuwa ni mzuri. Tukaja nyingine ambayo ni insufficient coordination. Coordination iliyokuwepo kati RCH team pamoja na CHW haikuwa nzuri. Tukaamua sasa kuhakikisha kunakuwa na coordination nzuri ili waweze kufanya kazi vizuri. And the other thing is the competing priority task ambayo ilikuwa na waathiri sana, ambao ni CHW. Wanakuwa na majukumu mengi kwenye kituo. Unakuta na jukumu ile na jukumu. Kwa hiyo hakuwa na ile kushindwa kuattain kwamba afanye kipi kwenye upande wa RCH, ilikuwa ni changamoto. Kwa hiyo CHW yote aliyokuwa anahusika na data za RCH tulitamani awe na message za kuweza kuwafikishia wananchi au jamii juu ya wao au umuhimu wa kuwahi kuanza kliniki chini ya wiki, mimba ikiwa chini ya wiki 12. So that all of these root causes zilichangia kuweza kushindwa kufikia target ya 30%, ambao tuliona hapo nyuma kwamba the highest performer was 24%. Kwa hiyo baada ya kuona hizi tukasema basi tuweze kuzitako, tuweze kusolve ili tuweze kuachieve ile target ambayo tunahitaji. Sio kwamba hizi initiative zote hazikuwepo. Kipindi cha nyuma zote hao walikuwepo. CHW walikuwepo. Hizo linkages zilikuwa zinafanyika, outreach zilikuwa zinafanyika, lakini kwa nini tulikuwa tuwezi kufikia target ya 30%? Kwa hiyo baada ya kuainisha hizi changamoto, tulienda kuzisolve na kuweza kuattain hiyo ambayo tulikuwa tunahitaji. Next please. These are the implemented strategies which we undergone. The first one was orienting the community health workers on the importance of early booking. Kwamba wale CHW wenyewe tulitamani wafahamu umuhimu wa mama mjamzito kuwahi kuanza kliniki ili aweze kutatua hizo changamoto. Kwa hiyo tukitegemea kwamba huyu CHW akishafahamu faida au umuhimu wa kuwahi kuanza kliniki, yeye atakuwa ni msaada mkubwa kwenda kwenye jamii na kuwaelimisha ili waweze kuwahi kuja kliniki. Lakini pia tulitamani kila CHW anayehusika aweze kuwa, kila CHW anayehusika aweze kulifaa mgonjwa. Tuliwapa target kila CHW mmoja aweze kulink wamama 10 kwa mwezi. Kwa walikuwa na hizo target. Lakini nyingine to review CHW compensation by making sure that health management team of the facility they make payment to CHW kuliko kwa wanakuja kituoni wanaondoka bila payment. Kwa hiyo kulianzishwa taratibu za kufanyiwa malipo ili waweze kufanya kazi zao. Lakini nyingine tuli improve RCH team pamoja na CHW kuwe na mahusiano mazuri, wafanye kazi kwa pamoja, na RCH in charge aweze kumpangia CHW majukumu na aweze kufanya shughuli zake vizuri. Lakini pia ni pamoja na kuwapangia ratiba kwamba muda fulani awe hapa au siku fulani awe hapa kwenye jamii, aweze kuhakikisha ile jamii inakuwa well sensitized na iweze kuwahi kuanza kliniki endapo tu yule mama atakuwa na ujauzito. Lakini kingine ni improve CHMT wenyewe kuweza kufanya supportive supervision kwenye vituo kila mwezi, lakini wao kama CHMT waweze kuwa wanakaa kwenye hizo situation room, wana review ile process, wanaangalia matokeo kama anaridhisha, kama hayaridhishi tuweze kufanya intervention kwamba ni kitu gani tumekosea au kitu gani tuweze kubadilisha. Next. Na haya ndo matokeo ambayo tuliyaona. Next please. Ukiangalia toka Januari 2022 mpaka Septemba 2022 hatukuweza kufikia 30%. Lakini baada ya intervention kuwahusisha CHW kwenye haya majukumu, baada ya miezi 6 tuliweza kufikia 30%, ambayo ilikuwa ni March 2023. Lakini baada ya March, April tulifikia 31%. Kwa hiyo basi tuliona kabisa kwamba CHW wanaposhirikishwa vyema wakapangiwa majukumu vizuri, wanafanya kazi kubwa kuweza kusensitize the community waweze kufahamu umuhimu wa kuanza kliniki. Next ya mwisho. Na haya ndo matokeo mengine zaidi. Ukiangalia kwa Temeke kwa mwezi tunaona mwanzoni Januari 2022 tulikuwa tunaweza kuona wamama 3973 kwa mwezi. Kati ya hao huu mstari wa blue wa kijani unaonesha wamama wanaowahi kuanza kliniki. Mstari mwekundu ni wamama wanaochelewa kuanza kliniki. Kwa hiyo utakuta mstari wa kijani kwa Januari ukiangalia, mnaweza mkaona hiyo line, ni wamama wachache sana ambao walikuwa wanawahi kuanza kliniki mimba ikiwa chini ya wiki 12. Lakini as the time goes, you can see out of 450 number of women, total number of women ambao wanakuja kliniki, kati ya hao mpaka Julai 2023 wamama 2045 wanawahi kuanza kliniki, na kati ya hao wamama 2000 tu ndio walikuwa wanachelewa. Kwa hiyo as the time goes, unaona hii gap ilikuwa inapungua mpaka tumefikia hatua ambayo kidogo iko ni ndogo sana. Kwa hiyo bado tuna nafasi ambayo tunaweza tukahakikisha tunawapunguza hao wanaisha wote na kuweza kuwakava wamama wote. Kitu kizuri ni kwamba Temeke tuna wamama wengi ambao ni wajawazito. Wamama 4000 ni karibu kwa sehemu zingine ni karibu mikoa mitatu. Lakini kwetu hapa wamama 4000 ni kwa mkoa mmoja. Kwa bado tuna kazi kubwa ambayo tunatakiwa tuifanye kuweza kuwafikia wamama wote na kuhakikisha wamama wanawahi kuanza kliniki. My take home message kwamba the data use inatusaidia kuweza kupinpoint sehemu yenye shida na kuweza kuifanyia kazi. Lakini kitu cha pili, CHW endapo wakifundishwa vizuri wanaweza wakaleta matokeo makubwa ambayo yatatusaidia sisi kama watumishi wa afya na kupata matokeo makubwa. Unaweza ukaona tulivyowashirikisha hawa mama tumepata matokeo ambayo ni makubwa CHW, ambao sasa tukiangalia tukiwa train wengi, kwa hapo utakuta ni watu wawili tu kwa mtaa ambapo ni CHW. Kila mtaa kunakuwa na CHW wawili, lakini tukiwapata wengi maana yake itakuwa ni rahisi kwa capture wamama wote ambao wako mtaani wanashindwa kufika kliniki na kuanza matibabu mapema ili kuweza kupunguza vifo vya mama na watoto. Lakini kitu cha tatu, naomba niishie hapo. Asanteni.
Ilala. Yes. Good evening, ladies and gentlemen. On behalf of Dar es Salaam City Council Health Management Team, I'm presenting to you how to improve the proportion of HIV positive pregnant and breastfeeding women receiving viral load testing. So in May 2022, an HIV design workshop held in Dar es Salaam City Council, and we have been seeing that we are supposed to review the data for the past or previous data from December 2021 to May 22 to reveal how the performance of viral load below the national target of 95%. As we see on the diagram on the right-hand side, we see the 60 months prior, since December 2021, it was 85. And when we are starting our project or workshop, we are in 78%. So we have some of the contributing factors which lead to low viral load coverage in Dar es Salaam City Council among HIV pregnant and breastfeeding women. We have some of the causes which leads to, that is an inadequate skilled, inadequate monthly data review, and inadequate mother-child cohort register documentation, as well as inadequate eligibility follow-up for HIV positive pregnant and breastfeeding women, inadequate provision of health education. And we know that all are the factors which contributing. When you see about the skilled healthcare workers, as an SHMT, we are the leader with leading to the health facilities on how to do the work at the facility level. So we are the first person to be taught about the high viral load. What is high viral load? What does it mean? What does it help for the pregnant women? And also, we see there's some of the improper documentation and submission of these data, especially for viral load and pregnancy women and breastfeeding. And also, we have some of the MC cohort register, which was not aware on how to document, especially in council level. So we have been seeing these issues, and we said that according to this, we are supposed also to be taught on us, then we will go to the facility level on how to fill this and how to own data and how to provide this education about viral load. As we see viral load in pregnant women, when it is high, it's very high risky to transmit HIV to the newborn. And we have an education to our clients or recipient of care that in 2022, we are not supposed to be a positive HIV child who were born. So that is the free generation in 2023. Next. So with some of the implementation we have been done, MC cohort register, as I said, for the SHMT members. And also we have some of the issues on documentation and the importance, because when you have no data, you have no right to say. So that is the main important issues we have been insist on it. And also we have conducted intensive data cleaning, and we have some of the implementing partners who are MDH, and also we have a DATA.FI. As usual, we are also doing for this cleaning of data. And this helps us to own this data. While when you have no idea on these cleaning issues, DATA.FI and MDH, they're supported on us. And also we have enhanced identification of eligible mothers of HIV viral load testing. As we know, we have a new algorithm for taking pregnant and breastfeeding women on HIV viral load according to national guideline. So some of their staffs, they are not aware on it. So as an SHMT members, we did it, and we are using these job aids on how to take the viral load for pregnant and breastfeeding women according to the national guideline or job aids. And also we have been distributed these job aids to the health facilities who are supposed also to use these job aids in order to take viral load for pregnant women and breastfeeding. And also we have some of the strengthening adherence counseling. We are doing the follow-up on all clients who need adherence counseling, especially for those who have high viral load. And when we said it is high viral load, it is above 1,000 copies. But also for pregnancy and breastfeeding women, when the mother have high viral load above 50, we are considering that is the dangerous signs to show up the mother will lead to high viral load. And also we have some observation to healthcare workers on providing adherence. So when we are doing mentorship and supportive supervision, we are seeing the clients at the ground, how they are counseling and how they are educating the recipient of care on how to give the education. So if there's any other issues concerning the adherence counseling to our recipient of care, we give them the feedback, and also we taught them on how to take a good adherence to pregnant and breastfeeding women. And also we have a promoted proper documentation, and that is the main issue which leads us to do intensive data cleaning. So if they have an improper documentation of the data, we lead to have a not clear data. So that is the aim of proper documentation, and we are not here for every month or every quarter to clean data, but when it happens, we are supposed to do it. So we have some of the percentage of HIV positive pregnant and breastfeeding women who are receiving viral load testing. We see that the data after implementation, there is changes. As I said, we have a previous of 6 months data. We have been driven, and we see they have a median before implementation started, or that workshop. So we have a 79% before, and after implementation, we see that of the changes. We changed from 79 to 85%, and we are proud on it, on how to take viral load for pregnancy and breastfeeding women at our facilities, and also we are not missing for those women who are eligible for viral load to be taken. So that is the next step. We promote data use and use culture of facility level by conducting orientation, especially in IMS, for easy performance review of viral load testing at the facility. From the beginning, we have not a power to own our data, but nowadays, after this situation room, we have been discussed as a HMT for the staff to own data. When you own data, you can do whatever you want to do, and you can identify also gaps to solve these issues, especially for pregnant women and breastfeeding. And also facilitate obtaining data use champions at the facility to improve activities on data around the viral load. So as we have been taught that when you own data, you came to obtain this data and you can use. So we on our own nowadays, I can say I'm proud of DATA.FI because they taught us as a HMT, and also we provide knowledge to health facility level how to own data. So we are now in our facilities in Dar es Salaam City Council, we are finding which the facility have been owned data and how to utilize it, and we will take them as a champion. So for the facilities who will be the best site, they will taught other facilities which do not do that. So we can use also the chart that will say that this chart will read us about the colors. We have a red color, we have a yellow, and we have a green. So for those sites, we have a red color we put in aside, and we have green colors we put aside. Then the green colors on the bar chart, or whatever the chart they will use, we use as a champion to teach other sites as a mentorship we are in the facility. So that is what we are doing in DATA.FI and the HMT at Dar es Salaam City Council. Thank you.
Yes. Kama walionitambulisha nadhani mtakuwa mshasahau kwa sababu amesha present sana. Naitwa Dr. Emmanuel Bia. Yes, Kinondoni tulikuwa tunafanya improvement ya retention. Improving 12-month retention rates. Next slide, please. Sasa, I'll be brief. Katika kufuatilia wamama mpaka kufikia viral suppression, lazima tuwa retain katika huduma. Kwamba kama tunataka wale wamama wapate watoto ambao hawana virusi vya ukimwi, lazima tuwa retain katika huduma. Kwa hiyo sisi kama Kinondoni tuliangalia sehemu hiyo. Next slide, please. Next slide. Yes. Mwaka jana Septemba 2022 tulikaa sisi kama HMT na tukaona kwamba median performance yetu ilikuwa 92, ambayo ilikuwa 3 points below national targets, kama tunavyoona katika hii presentation. Kwa hiyo Alive on PMTCD care ilikuwa proxy ya ile viral suppression ambayo tulikuwa tunaifuatilia. Next slide, please. Next slide. Yes, tukaanalyze matatizo ambayo yapo katika eneo letu. kwamba ya kwanza of course ilikuwa as presenters ambao wamepita wameisema, documentation ya tools hasa PMTCT cohort ile ina changamoto kidogo katika presentation. Kwa hiyo tuliangalia hilo, lakini pia la pili ni data review session katika level ya kituo ilikuwa ina changamoto. Vituo vingi hawa review data katika level ya kituo. Kwa hiyo wanakuta wana submit kitu ambacho sicho katika level ya halmashauri. Lakini sasa sehemu nyingine ilikuwa sisi kama halmashauri kureview data zetu na kumonitor namna ambavyo zitatumika katika kufanyia decision. Kwa hiyo hizi zote zilileta katika ile median ya 92% on alive on care. Next slide please. Yes, kwa hiyo tulifanya at least vitu vitatu ambavyo vilitupelekea katika kuimprove sehemu yetu. Of course ya kwanza ilikuwa capacity building. Sisi wenyewe kama CHMT tulijengea uwezo of course na wadau wetu Palladium pamoja na FDH kwa ajili ya kuangalia hizi tools, kwa sababu huwezi kumfundisha mtu kitu ambacho ukijui. Lakini pia this time we were conducting forecast data driven supportive supervision. Instead of kuamka na kutoka na kwenda tu moja kwa moja, lakini tulikuwa tunakaa katika situation rooms na kuangalia what is wrong and where to tackle it. Sawa? Lakini sehemu ya tatu, develop data validation rules on IMS, kwa maana ya kwamba errors kwa zile errors ambazo zinatokea, you validate what is wrong with the data and then perform data cleaning. Next slide please. We see for the last 4 months kutoka May mpaka August we had 92 as I presented earlier. Then baada ya kufanya review tukawa tumefikia at 97% katika hizi alive on care. Kwa hiyo review ya data ilitusaidia sana katika kuangalia improvement ya who is retained on care, ili baadaye to attain ile viral suppression na kupata mtoto ambaye hana maambukizi. Next slide please. Yes, what have we learned from this forum? Data reviews by CHMT in situation rooms have provided us a room for conducting a forecast, supportive supervision among health facilities, but also this should be sustained. From 92 to 97 is not a joke, kwa sababu sisi wote tunajua tumefanya kazi katika hayo maeneo. Kwa hiyo this should be sustained, but also tunakuwa na changamoto kidogo kwenye baadhi ya staff kuwa hii haijawekwa, lakini natamani niseme pia tunafanya supportive supervision, lakini wale staff wanakuwa changed. Sasa unakuta mnakuwa mnafanya alafu wanarudi. Kwa hiyo sasa of course tulikaa katika situation room pia tulikuwa tunaangalia hilo eneo na kuangalia way forward ya kufanya. Otherwise mimi nipende kuwashukuru sana. Karibu.
Mabibi na mabwana, habarini za jioni. Tuende kuona namna ya kusustain situation rooms. Tuliandaa ma-champions ambao wanaweza kusustain situation rooms na kuendeleza namna ya uchakataji wa data. Kwa namna nyingine ambayo tunaweza ku-maintain ama kusustain situation rooms ni kuwa-engage wale stakeholders. Next slide please. Was it responsible? Yes. Kama tunavyoona hapo kwenye slide, CHMT wanafanya supervision, lakini supervision ziko kwa data driven. Kwa hivyo ili sustainability iwepo lazima hayo yote tuyafuatishe, lakini kuweza kuweka kwenye bajeti zetu namna ya kuweza kuendesha hizo situation room kama maintenance, internet pamoja na transportation. Next slide please. Katika situation rooms ili tuweze kusustain lazima tuweze kuweka mikakati ya kujadili weekly basis ili tuweze kufanya maamuzi yaliyo sahihi. Mtaona nakwenda haraka, lakini ni kutokana na yale yote ambayo yamefanyika. Mimi namalizia tu, niko miongoni mwa wale wenzangu walioyasema. Kwa hiyo mimi nakwenda kuona namna ya kusustain. Next slide. Faida mojawapo ambayo tutaiona, benefits and adaptation. The CHMT to provide continued technical support to the health facilities on good documentation, data review, analysis, and use of data and decision making. Yule champion ama situation room champion, hiyo ndo kazi yake, kuorganize CHMT na kuweza kuweka progress ya ama series ya documentation ya data ambazo zinakuwa reviewed na namna ya analyze. Lakini finally waweze kushare ama kureport findings kwenye higher level. Next. Tuone conclusion. Sustain data use via weekly situation rooms, then continue data driven process and decision making such as supportive supervision, to continue optimizing resource allocation and distribution, then implement data use in more indicators to drive the improvement. Then lastly, continue cross-learning of best practices among different councils. Asanteni.
Asanteni sana all the presenters for very good and massive presentation. I hope every one of us have enjoyed every minute being in this room. So now we have 15 minutes for Q&A session. So if you have any question, you have any query, you want to give advice, you want to give your comments, please, now is the time. Karibuni sana.
Thank you for the opportunity and congratulations for the panelists. I just wanted to know, just to clear my mind about this project, because it seems that it has a very successful outcomes. And how do you plan, I don't know if you have enrolled throughout the country. If not, how do you plan to enroll it through the country? Because if we have few councils with that success, I imagine if it goes around the country, how our clients will benefit with services, but also the facility itself will be able to finance themselves in learning their services. Thank you.
Thank you very much. I think we can take 4 questions, then the panelists will respond. Karibuni sana.
Thank you. Thank you, the presenters. Mine is somehow related to the previous question. I just want to know your strategies when it comes to having a system-wide improvement. Because what you have presented is more of like, I would call them pockets of improvements. And they appear to be more disease-specific, which is fine. But how can we move from these pockets of improvement to system-wide improvement? Could be within the regions, not necessarily across the country, but these are more of councils. Now, how do we move to the regions, zones, and then get to the national level? What are your strategies? Thanks.
Next, please. Kaka. Up. No. Okay, is there anyone else with a question or comment? Or we can let the panelists to respond to the two questions that are raised. Okay, I think hakuna. I think Dada Stella, the first question goes to you. And maybe you can help us respond.
Asante sana. I think the question is about rolling out. Swali ni zuri, lakini ningependa sana lijibiwe na PO Large. Kama mlivyosikia mwanzo, the essence, hii initiative imetokana na request kutoka PO Large. Na tulipata nafasi ya kuimplement kwenye mikoa miwili. Kwa hiyo ningependa sana PO Large waweze kutuambia plans walizokuwa nazo as far as rolling out is concerned. Karibu.
Thank you very much for very important questions. In principle, we had dissemination meetings around 2 or 3 weeks ago, and the purpose of the dissemination meeting was actually to share the best practices that came out of these projects. So ideally, we invited some partners, implementing partners in the different areas in Tanzania. So they came and we disseminated the projects. And to most of them, as you already said, it clicked to their mind that it's a good project. So the main way forward was to think how best now we can accommodate this project in the component of data use in their projects. Because most of the projects that are implemented in the councils, they have a component of data use. So we want to borrow the best practice for this project for implementations in their areas. And the second strategy is really to see how best in some of the activities completed in the CCHPs and facility plans. Because there are some of the components that as a council of facilities, they usually planned for them. As you have seen also in the sustainability plans as presented, so we are going also to accommodate to those areas. So the key takeaway message, we wanted to advocate for the top leadership of PRAG to understand, and in that meeting they were there and they took it as very positive. And the second thing is to the partner. Thank you.
Thank you very much for the response. Is there any question, comment? Karibu sana baba.
Asante sana. Mimi nataka kufuatilia hapo huyo PO RAG alipoishia hapo kwamba yes wamekubali, atuambie what's the time frame, kwa sababu hii results positive hizi zitabaki na hawa ambao waliparticipate kwenye program, lakini system nzima ya PO RAG kama haijakuwa transformed kufuata nani na kwa kipindi cha muda wa karibuni hivi, mambo yatarudi yale ya kusema turudi kule nyuma. Labda angetuambia what's the time frame katika kubadilisha transformation inakuwa effected in the PO RAG. Hiyo ita involve kuchange policy na nini, kwa sababu lazima sera zingine zibadilike ili kuhakikisha kwamba hii inafaka kwa. This is a very, very positive thing, lakini it is a pilot. It need to be scaled up ili nchi nzima hiyo inafuata hivi ili tuweze kupata results that are really positive.
So can we have a response from PRAG? Okay, there's another question.
Sorry, I'm asking the second question, but I just want to hear from you. If I check the facilities that you included, most of them are in urban setting. Of course, the data started from Makole, which is in urban, Mpwapwa, Dar es Salaam, and Temeke. I'm just wondering if this model can work in a remote health center for example, in some villages, if they can adapt this model, is it feasible at that setting? Because when we are scaling, probably we need to go up to the lower facilities, away from the district level.
Okay.
Thank you.
Is there any other question? Karibu sana mama.
Thank you very much for this very informative session, and I'm just curious in terms of the data analysis, and I will appreciate to learn from the councils where they have implemented. Are they using this information also to analyze other data sets they have from other programs? Because I see this is a very important area where we really need to work more in improving the use of data, and I'd just like to hear from them that are they using these skills to also to look at other data in their respective councils. Thank you.
Asante sana. So I think we can have a response from PRH. Then after that, we'll go to all the presenters to tell us, do they use this data analysis in all indicators? So Dr. Kengia, I think you remember the question that you have to tell us about the time frame, like when do we expect to roll out throughout the country?
That is a very critical question and very important. In principle, we had the similar questions while we were disseminating this project. But the good news is this one is actually in line with the PRORAG quality improvement roadmap. That's for 2022 up to 2017. So we expect that within the same roadmap of quality improvement, because ideally this is part of quality improvement initiative, we are going to ensure that we roll out countrywide. And I think the other question that was raised was the issue of the rural settings. So in this project, while we were designing it, we really took in consideration of the facilities for rural urban. So we had some selection with the very specific criteria and the inclusion of rural facilities there. Yeah, because you're talking about an area like Mpwapwa, yes, but there are some of the facilities which are in rural settings. And of course, municipal setting, you can have the facility, but all the selections were based on rural urban settings. Maybe if is to talk about the issue that was raised also about the system-wide approach in terms of implementations. That is also very important, and I think in the sustainability slides, you also saw that we also advocate for kind of a spillover effect of these projects. From the indicator, we select specific indicators that are limited in HIV or the likes, but now as important spillover effects, we want to make sure that the same approach is being utilized in health, social welfare, and nutrition services. Because at PRORAG, we usually coordinate the three.
Thank you very much, Dr. Kengia, for the response. So now, quickly, 1 minute, I would like to welcome all the panelists to respond to the last question.
Hello? Yeah. Yes. Swali zuri kwa swali la mwisho kuhusu tunatumia kama tunatumia kwenye issues nyingine. It's yes. Kwa kuwa kwa sasa hivi mfano kama sisi Kinondoni, nitajibu kama Kinondoni, DMO has been very strict. Kwa maana ya kwamba tumeshajengiwa uwezo. Kwa hiyo ina maana lazima tuutumie katika ku decide vitu vingi sana pale halmashauri. Tumeshafanya problem analysis katika maeneo mengi sana katika council yetu. Of course hatujaweka katika presentation hapa, lakini tulishaanza kwa sababu alisema kwamba hii sustainability lazima iwepo, hata kama kesho kutwa yeye hayupo, lazima vitu viende kama ilivyo katika mradi ambao ulituachia. Nadhani kwa upande wetu iko kwa muktadha huo. Asante.
So Mpwapwa, can you please respond?
Asante, lakini pia sisi Mpwapwa hatuko tofauti na presenter aliyepita. Ni kweli tunaendelea kuchakata data katika indicator zote ambazo zinaonekana zina shida. Kwa hiyo tunatumia situation room kuchakata zile data. Tukiona kuna indicator yoyote katika data zile, tunaanza kuifanyia kazi. Kwa hiyo sio tu kwa ajili ya mambo ya HVL, na data nyingine tunazifanyia kazi. Asante.
Labda mimi I'm not from CHMT, I'm from DATA.FI, so mimi labda nitalijibu pia generically tu, ambayo linafanana nafikiri na swali liuliza mjumbe mmoja pale akutaja jina, kwamba hata the methods of DATA.FI, majority of them zilikuwa ni generic, kwa maana ya kwamba it's about, for example, data use ambayo au quality improvement, na in particular the coaching pia ilikuwa ni broad, kwamba how can one use data to improve health performance, how can one employ QI technique. And so you can see kwamba in particular maeneo ambayo tuliyagusia wakati wa mradi ilikuwa ni kutoa like ule mwongozo, kwa sababu then you want people to gain the skills, so we wanted first to focus, na ndio maana haya eneo la ANC pamoja na HIV yalikuwa ni maeneo ya mfano. And now as you can see kwamba we could then demonstrate impact kwenye haya maeneo, which seems like a pocket, lakini the lesson has been learned kwamba you could in fact extrapolate the methods na ukaweza kuapply kwenye maeneo mengine. So even the method na project ilikuwa designed kuweza kuoffer kwamba ANC na HIV kama pa kuanzia, lakini pia to be able to scale up.
Kwa Temeke pia tunapitia maeneo yote ambayo ni ya muhimu, specifically the 10 priority areas ambazo zipo. Kwa zote tunazipitia kwenye mfumo. Zipo nyingi, kuna malaria, kuna HIV, kuna TB, kuna ANC kama tulivyoona, RCH, lakini kuna finance and governance, kama kituo mapato yake yapoje, tuna display kwenye situation room, kituo kipi ambacho kinakusanya kidogo, kituo kipi, lakini pia tunaangalia na exemption, kipi kina exemption ndogo, kipi kina kubwa. Kwa hiyo kupitia hizi takwimu ambazo tunazitumia.
Asante kwa swali zuri. Kwa upande wa Dar es Salaam City Council, sisi imetusaidia, kwa mfano tumeweza kuanza ufuatiliaji wa magonjwa yasiyoambukiza kwa maana ya non-communicable diseases, na pia imetusaidia kuona kwamba we are not only dealing with HIV clients only, but other clients who are living with HIV, they have other diseases like hypertension. So katika halmashauri ya jiji tumeweza kuchagua vituo 5 ambavyo katika hivyo vituo 5 viko ndani ya, yani kwa maana ya city center na nyingine nje ya mji, ili kuweza kufuatilia vizuri wateja wote ambao wana high blood pressure, na pia kuweza kufanya well documented na kuweza kuanalyze data ambazo tunazipata kwa wateja ambao wana high viral load, wana high blood pressure. Na hiyo imetusaidia pia kuinvite kupitia kwa mganga mkuu wa halmashauri ya jiji la Dar es Salaam kuweza kualika ma specialist. Sasa hivi we are very very happy baada ya kuweza kuita physician na kuweza kuwahaya kwa wale ambao wanaenda kwa extra time hours ili waweze kuwaona wateja. Tumeweza pia kuanzisha special clinic za NCD ili kuweza kuwafuatilia wateja. Na ninavyosema pia leo tumeweza pia kuanza kuanalyze kwa upande wa takwimu zetu, baada ya kwamba every Wednesday we are supposed also to review data. So we are starting with malaria, na tukajiona pia hatukuwa vizuri. Jana tuliweza kupitia takwimu zetu za chanjo, tumeziona pia ziko vizuri, but some of the areas we need some of the implementations. So we have 2 tasks from nowadays, lakini moja tayari iko on board na tumeweza kuanzisha special clinics during the working hours. We are proud of it.
Asante sana all the panelists for a very nice experience sharing from your councils. I believe kila mtu ameona importance of using data, analyzing them, gap identification, and at the end of the day making decisions on the data. So that marks the end of our forum today. But before that, I would like to take this opportunity on behalf of Pure Raj to give our special thanks to DATA.FI. Dada Stella, please, peleka salamu zetu. Thank you very much for the support on the situation rooms. We have all seen how much the CHMTs have improved, in terms of data use and gap identification and decision making using data. So thank you very much. And we call upon all the CHMTs and all facilities. Now, data should be a core business, that you have to use data, making decisions, identifying gaps. I'm sure we'll go somewhere. So asanteni sana, and please have a pleasant jioni. Asanteni sana. Oh, na kesho asubuhi from 8 to 9, we are going to have a forum which will be presented by Pio Raj. I think it's going to be at Ruaha Hall. And the topic will be performance, management, and accountability in primary health care, discussing the role of the performance contract and the scorecard. Please don't miss. Karibuni sana.
Their experience and success in how they are really using data for decision making and how that is helpful in our journey to msiondoke. Moderator, the panel, we need ukumbusho kwamba this actually happened. Watu wa data sisi na kuonyesha kwamba this actually happened. So pamoja na viongozi wetu wa Pio Raj na wakaribisha hapa. Kamera zetu ni hizo za simu, tufanye mambo hapa tupate ukumbusho. Nadhani tukisimama hapo chini ni vizuri zaidi. Wengine wanaweza kusimama nyuma, wengine chini, ili pia tuwe na hiyo background na tutumie simu zetu kuwapiga hao ndugu zetu picha tuweze kuwa nakumbuka. Dr. Kengia pale tunakuomba na viongozi mliopo pamoja na jamani, kinachofuata muda huu ni awards kwenye Ruaha na cocktail session. Kwa hiyo all that will happen, the awards will be in the Ruaha Hall and the cocktail will be in the lobby and there's music as well. So mbona wengine wale ambao mmependa kuwakinga wengine mmewakinga kweli kweli? Kwa hiyo ni kwamba sikilizeni, wale ambao mmesimama huku backbencher msimame chini ya ground. Yeah, afu wengine wasimame hapo juu. And then kila mtu anakuwa na equity. Ambao mmesimama juu ya step, mwendelee kusimama juu ya step, afu ambao wapenda kuwakinga wenzao waje pale mbele kabisa. Yes, umeona? Kwa hiyo tunapata kitu kinaitwa equity. Tunaangalia jinsi tulivyo. DATA.FI for decision making. DATA.FI for UHC and primary health care. Hawa smile lakini, yani watu wa data hapo kumbe wana smile. Umeona? Wakiziangalia namba sana zinakuwa pesa. Yes, so one more time, 2 more photographs. Asanteni sana. Mungu awabariki. Tunaendelea na Mikumi kesho saa 2 kamili. Tutakuwa na forum.